Hello, everyone. I am Dr. Bernadeia Johnson. It is such an honor to be here with you for the annual National Mental Health Policy Institute. I first want to recognize Sue Abderholden, the Executive Director of NAMI, and the other community organizations, and Jim Johnson and other district leaders who joined me at the table to think about how we could optimize our unique organizational skills to support the mental health of Minneapolis Public Schools students, and in turn, to create the mental health model that I will share with you all today. Let me begin with a question. Is there anything more important than the well-being of our children? I imagine all parents would quickly answer no. And that would be echoed by grandparents like me and most others. We have all known for a long time that our children are facing challenges to their mental health. This organization has often documented these needs. And after this last turbulent year, those needs have become even more pronounced and present us with even more urgent calls to attend them. And yet the barriers to doing just that are familiar and remain. It is in fact those obstacles that I would like to address today. Let me start at the end. This year, mental health clinicians from our community will work alongside educators in every school in Minneapolis Public Schools. Their services will be available to any student, regardless of family's ability to pay. Many, not all of our immigrant children will be able to receive the services in their home languages. Again, many, but not all will see a clinician who looks like them. It is a journey that began in 2004. A journey joined by teachers and administrators, mental health agencies, clinicians, students, families, and advocates, politicians, insurance companies, charitable foundations, and researchers. From the beginning, all were involved. All signed on to the goal of ensuring that children had access to the mental health treatment they needed and that schools become a place that better supported their well-being. All worked to come nearer to the solution. It meant acknowledging barriers each erected. It meant being transparent. At the beginning, through policy and rules, mental health services could not be delivered and paid for in schools. Mental health agencies were afraid to commit the staff. Insurance companies refused to pay for services delivered on school grounds, and politicians were afraid to open the floodgates of accessibility. Schools did not see their role as to provide treatment, and the union did not want other professionals working in the school taking away their jobs. Issues of structure, effective and culturally competent treatment, payment, and privacy were all like castle walls, high, impenetrable, and ancient. But the children, parents, and teachers were naming the need. And so those are the barriers, each named, each supported by policy and rules. Who would do this? Who will pay for it? Do I dare trust that if I give up my power, which I've carefully crafted the rules that have been made to protect my interests, others will not take advantage of me? Do I trust I will not be left holding the bag, expected to change too much, be made to feel uncomfortable? Well, as superintendent who participated in the development of this program, I can tell you, those are real questions. But what I found was that there was enough people who heard the first question loudly. Is there anything more important than the well-being of our children? And they were willing to begin that journey. So let me tell you a short version of our trek through the unknown. As the superintendent of Minneapolis, I was trying to shift the experiences and outcomes for all students, but especially my BIPOC students, who for every indicator of school success were at the bottom, and for every indicator of school failure were at the top. I was seeing how the absence of mental health support was having an impact on students' experiences and outcomes in schools. I saw a persistent rise in school suspensions, low academic achievement, increased school absences, and referrals to special ed. I began to realize how the trauma that many of our students were experiencing in their community was impacting how well they were doing in our schools. That realization is clearly evident in our city of Minneapolis and other cities across this nation. Our students, and I mean our share students, are experiencing these increased traumas. They are isolated from their peers and other social networks due to COVID. They're experiencing increased gun violence in their neighborhoods that lead to loss of life. You all know about the killing of George Floyd. And here in our city, we have seen an increase of children being shot and barely hanging on to life. In Minneapolis right now, we have 4 children in the hospital from gun violence. The youngest was shot while jumping on a trampoline at a birthday party. All of us know the consequences of COVID and bringing loss of life to our families, and mine included. And if one of those 4 children just passed away last night. Like most school districts, Minneapolis didn't have the level of services, support, or expertise to adequately help our students address their mental health needs, to develop the resiliency and skills to survive and ultimately excel in our school environments. This was especially true for our BIPOC students. The traditional model of families seeking mental health support outside of school was not a model that worked. Families struggled with engaging in services due to work and insurance issues. And when they did, the average course of treatment lasted only 5 sessions, often not long enough to be effective. Additionally, there was little contact between the agency and school, so students were not supported in practicing their newly acquired skills. We worked to engage the system and partners who are already in the field of mental health in our community. We didn't want to create a new parallel system. Local organizations, both public and private, who already had the sanctioned mission to provide mental health services for families that had the structures, systems, and processes already in place, joined us at the table to do what they did best. We all came to the table as experts in our own field while understanding the overlap of our responsibilities to ensure that our children had the foundation and sense of well-being and the education they needed to reach their potential. And yes, we all came to the table with our checkbooks, guided by the principle that we would accept responsibility for paying for the services as appropriate for each entity and work together to manage any excess cost. By engaging with community providers, we were able to bring agencies that already had visibility and credibility in the community, some that had already been around for decades. Some had special expertise in providing services to specific communities, especially underserved communities like the African American, Latinx, Indigenous, and immigrant communities. Because they were known in the community, they came with the community's trust, which was critical to overcome the hesitancy to engage in the services and to address stigma. We gained one more benefit. The mental health agency also had the same workforce challenges we had in K-12, and that is a diverse group of providers and clinicians. These agencies took on the additional responsibility of providing training and professional development of clinicians, especially clinicians that look like communities we served. To aid the schools in providing an environment that was better able to support all students, the school-based mental health clinicians set aside about 1/3 of their time to provide service to the school staff. This involved consultation about school strategies and classroom strategies for students, professional development on topics such as typical child development, culturally specific practices, trauma, anxiety, depression, and strategies for identifying mental health concerns. Schools were required to set aside time for the mental health clinicians to provide this professional development with the end goal of creating classrooms which are more supportive of all students. One final but important note, privacy is a critical feature of bringing mental health services into the schools. By engaging the community providers, we were able to ensure that the same standard of privacy required in all health settings will also apply to our program. All information and records belong to the agency and only shared with the permission of the parent and as necessary to support the child in the school. We started with 5 schools in 2004, and when I left in 2015, we were at 38 schools, and based on information shared with me recently, services are now located in all schools. Our data has demonstrated, and we educators have seen the result of the school-based mental health model: improved attendance, a decline in suspensions, an improvement in academic outcomes. Teachers reported improved behavior and engagement. Children experienced improved well-being. Parents reported that their children are better off. As a policy proposition, a return on investment in supporting our next generation reaching their dreams and potential, I call it a success. A risk worth taking, an effort worth making. a question worth answering. Nothing is more important than the well-being of our children, our next generation. Thank you for your attendance in this conference.